And now we're going to be doing more advanced exercises. These are much more difficult and much more rehabilitative. We want to be careful to put the bottom of the fulcrum in line with the crest of the ilia or the top of the hip bone here like that. Equal on both sides. Put the neck block tight against the shoulders. Now what we're going to do is keep the feet a little bit farther apart, maybe shoulder width apart. We're going to grab on the thighs like this here. We're going to push on the thighs in such a way that we're actually slightly decompressing our weight on the lumbar fulcrum. You could actually push so hard that you're off the fulcrum, but your shirt or clothing is still touching the fulcrum. So it would not be done like a pelvic tilt. We would leave the arch in the lower back and just push all of the body weight onto the neck curve. Would slide the hands up enough so that the shoulders are away from the neck and not crunched up like this here. So we'd push them out, come way up high, tongue in the frenulum, and we would do chin tucks. Now with all my body weight on the neck block, this is very, very, very strong rehabilitation for the neck region. And again, in the same protocol position, pushing up, putting all the neck weight on the block, we would side bend. Again, sliding on the fulcrum and try to keep the chin in midline and go into lateral bending. And that is a very, very, very powerful neck rehabilitation exercise protocol. Then the third exercise would again be pushing on the thighs again and turning, but putting a very, very strong effort in rotation so that the eye line goes down and looks at the floor from both sides. Again, keeping the upward gaze so that the cervical spine or neck curve is kept in its full curve or full lordosis. So I'll go through them again quickly. All the way, chin tuck. Lateral bending. Rotation. Now those are very, very powerful rehabilitation exercises for the cervical spine. Now we'll go into the lumbar spine and more advanced exercises. Because the blocks will tend to move around when you're being very aggressive, we'll constantly have to reposition them. So like we did the single leg raiser, we put the foot off first, brought the pelvis up, and then we stretched the knee up to the chest. So in the double knee raiser, that's a very, very advanced exercise. We would probably want to do this next exercise first, which is lifting the chest off the floor and starting to engage both psoas muscles concurrently. So we would put the hands in the cross-down position over the chest. We would continue to tighten up the relationship of the blocks, extend the feet out a little bit further for leverage. We would take the chest cavity and just lift it off the blocks. And doing a mini sit-up, if you will, but not a sit-up in which we would tuck the chin, because that really causes a very disproportional relationship of the three primary spinal curves, especially neck and lumbar spine in this case here. We would want to try to keep the head in line with the torso. And so commonly I'll have the patient hold high up on the chest, even pinning the chin with the forearms in such a way that there is no forward head translation when we're doing the lift. Again, this is a very strong rehabilitation protocol. You'll see a lot of people doing sit-ups and like this here, and about halfway through that range of motion, there's no more effort required. This is the hardest range of motion, what we're suggesting in those small lifts like that. And so in the more advanced stage, we're going to get the feet out, we're going to raise the chest, and we're going to side bend the head and neck, and we'll let the knees flip over to the other side just simply for counterbalance. Strong lateral flexion of the head and neck, and swing of the torso over the pivot point of the fulcrum in the lumbar spine. And that is a hugely powerful rehabilitation protocol for making low backs strong as bulls. So now we're going to reposition the fulcrum again. We're going to go into the last phase, or one of the last phases, and do the double knee raisers. Commonly, because I'm so tall, I'll put my hands out like this here. Lighter people, shorter people will actually have dumbbells, or putting your hands under a piece of furniture at home. Raise the feet off the floor, but not the pelvis. Then get the pelvis off the floor, and then bring the knees up to the chest and stretch them. 1, 2, 3, 4, 5. Hips, feet, feet, hips, chest, stretch, hips, feet. And that exercise, again, is a very, very powerful exercise. When one gets command of this, then they will start to have an extraordinarily strong lumbar spine. Now, in the more advanced phases, we can bring the feet up, bring the knees up to the chest, bring the knees over, and start to stretch the hamstrings, and really start to stretch the lumbar spine as well. And bring them back in, bring feet to the floor, okay? And that is a very, very, very good exercise as well. Now, the next one, which is a very, very advanced exercise, and I wouldn't volunteer unstable patients for this. We're going to bring the knees up, get the feet up. Now we're going to get down and touch the heels on the floor and do the leg raiser exercise over the lumbar fulcrum with straight legs. And I'm going to tell you that this is a very advanced exercise protocol for you. And if you want to get into the very, very advanced stages, you can take the hips and move them out. I'll move over a little bit so I don't hit that object, and reposition the fulcrums. Get up and straight, and move the hips out. Help with the hands if you need, and like that. So that it is easier for less functional patients to just do it on the downstroke. On all of them, for example, if a patient cannot do the double knee raiser, we would have them cheat. One leg at a time, get it up, let them both down at the same time. So just going on the downward stroke would start to rehabilitate them in a more gradual way. In the one of the most advanced exercises, getting the knees out, and would be a very, very wonderful way of really opening up that lumbar spine and creating such a dynamic strength in lateral flexion on the lumbar spine, again with controlled pivot point, would be a pretty profound rehab protocol.